So, good evening, everyone, and thanks for joining tonight's webinar from the Body Doctor. Before I introduce our two special guests today, I just have a few housekeeping things that I need to get done, basically. So the presentation should last around an hour, and there's a bit of a Q&A at the end. If you've got a question, just pop it in that chat box, and we'll try and get through as many as possible. There is a lot of yous here today, so I'll do my best to direct them to Ros and Purvi, and we'll get going. And then also we would normally unmute people and get you to put your hand up, but as there's so many of you, it'll be carnage. So at the end of the webinar, you will get an email from WebEx as soon as it's over, and that will have your instructions on how to get your CPD points. So it'll have a full, if you've got any issues with that, then just pop us an email. You can find the email on the website, or if you can remember it, and I'll put it in the chat box as well so you can refer to, it's marketing@the-body-doctor.com. It is a very long email, so do bear with me. And then moving on, tonight's session covers cataract, the why and how of pre-surgery dry eye management. It's a CPD lecture led by Purvi Thomson. She's a lead optometrist at OCL Vision. Purvi is a specialist optometrist who, since qualifying in 2004, has then gained vast experience in different sectors within optometry. For 7 years, she worked and managed at a high street practice before moving into the hospital industry, and she's yet worked with OCL Vision since 2014 as their lead optometrist. Purvi is tonight supported by the Body Doctor's Learning and Development Manager, Ros Musa. So, as you probably already know her. Ros Musa is a highly skilled professional with 30 years experience in the industry. In practice, she works as a CLO with a special interest in dry eye disease. Over to you now. Take it.
Thank you very much. Thank you so much, guys. You will also have a QR code at the end, so don't panic.
Oh, yeah.
Do have your phones ready. But as Leanna said, if that's a problem, just email us and we'll get everything out to you. And we'll get going. Thanks a lot, Purvi.
And thank you so much for that introduction.
See you later. See you earlier.
No worries.
And I am going to share my screen. And Rosie, you will just tell me.
Yes.
Yep, we're good.
That's perfect. That's lovely.
It's nice to meet you all. My name is
Nicola, I'm glad to hear the sound's all good now. Thank you. Sorry.
You're fine. My name is Purvi Thomson and I'm an optometrist at OCL Vision. And actually a lot of what I do at OCL and the whole team of what we do there is we do all the pre-op and post-op. So we work with a consultant. So we'll do all the pre-op consultation for cataracts and laser. And we also do all the follow-up. So that's laser, cataract, corneal. And we also independently run a dry eye clinic there. And so a lot of what we're going to talk about is what we do there and why the management of dry eye is so very important for patients that you are referring for cataract surgery. So just the objectives for this evening is the importance of going through a clinical assessment and managing the dry eye in community. So this is everything that as optometrists we can do in the community, whether you're in hospital, doesn't really make a difference if you're not ophthalmology. Honestly, it's what you do on the high street when you're referring those patients in before you refer those patients in, how you can help them. We'll talk a little bit about the ocular surface and why it's important in a refractive and cataract context. The reasons for dry eye during, intra, post-operatively, and this is really good for you to educate your patients about, of why they might be suffering for dry eye post-surgery and also why they need to optimize their ocular surface before they have any surgery done. I always find the best way to educate is from cases. I love learning from actual real life cases. Ros, I don't know if you're the same with that. But
it's really, I think that's the best way, right? You put all your science together and you look at actually what's what's happening in front of you, and actually that's what makes it come together.
It does. It's a great learning tool, you know, have things in real life context. So there will be some cases from OCL Vision, and also a little bit about how you can incorporate a dry eye clinic into your practice. You know, we know as having your own optometry practice, being an optometrist, it was also a business. You need to have a business there for you to survive and be able to treat your patients the best way you can. And you can incorporate a lot of these things. Not only are you helping your patients, but you're helping your business to grow, and you're also learning through it. It's your own clinical skills that are growing, so it's a win-win for everyone in the end. So just a few facts really, which are quite handy. So this is from the TFOS Dry Eye Workshop, the June 2017 publication. Found out the prevalence of dry eye based on symptoms with or without signs is 5 to 50%. So that's actually a huge broad range. So this is just patients complaining of having issues with their eyes with signs or without signs, This is just them talking to you about, and you might have 5% on your seat, you might have 50% of everyone coming into your seat, but it's a really broad range. The prevalence of dry eye was higher, so 75% of patients. So what that says to me, and what that should say to you guys, is actually patients aren't complaining of dry eye symptoms or ocular surface issues, but when you're looking at them, you are recognizing that actually they do have dry eye. So you need to then educate them on how they can manage that, because they will otherwise go from asymptomatic to then being symptomatic. And the symptomatic dry eye patients are the hardest to manage in terms of their expectation. Patients that are asymptomatic who have dry eye are actually clinically can be very difficult, because they can go on to have further problems because they're so asymptomatic. But those in your chair generally will be the ones that have signs, and if they don't have symptoms, what you don't want to do is make sure you tip them over to symptomatic, because they do become a bit of a problem actually. Women, higher prevalence than men, and we'll go through a little bit about that and why women do have a higher prevalence. And it's higher in the Asian than Caucasian population. So it's just for you to think about when you've got someone sat in your chair and they're complaining, just look at their demographic and think actually they fit typically with someone who might present with dry eye. And also, Ros, this fact, almost 50% of patients with dry eye disease have mental health difficulties. I don't know if you found the same, but these patients were really unhappy in the chair.
Yeah, I mean, it's a strange thing. So I've often talked to people about this, other clinicians about this, and obviously it's variable, right? But what this says to me, this is a real quality of life issue. And that patient that is just, I don't know if you've ever had this, Purvi, right? That patient that is just a misery, right? You're just a misery, and there is nothing you can do to make them happy. And suddenly you treat their dry and they come in like a completely different personality.
It's true. How many sat in your chair and cried?
Sorry?
How many of these dry eye patients have sat in your chair and cried? A
Oh,
lot.
I actually had that happen last week, and yeah, that wasn't very nice. That has happened.
It's really tough. So in the context of cataract, there was a FACO study that came out in 2017. And this is really interesting. So 22% of patients entered the study with already a diagnosis of dry eye. They knew when they came in that study that actually they had dry eye. Great. 30% had dry eye signs and symptoms. So already a few more percent had signs and symptoms, but they had no diagnosis of it. They didn't know. 63% had a tear breakup time of less than 5 seconds. So these patients have got ocular surface disease. They do have dry eye, 63%, but yet only 22% knew they had dry eye. And 77% of patients had corneal staining. So in this study of patients going for cataract surgery, 77% of them had corneal staining. And actually, as we go through this webinar, what you'll learn is why the staining itself can have a huge impact on their outcome, not purely on how they feel after surgery, but also what they see after surgery. And it'll be quite eye-opening, literally. So why does this matter? Why are you here? Why are you listening to me speak? And why are you here with Ros as well? Is actually with these patients, you will send them off to have cataract surgery. More than a third of these patients will develop dry eye disease afterwards. So actually, when you refer your patients on, you need to tell them that temporarily, post-cataract surgery, you will get dry eye disease. And so it's not me referring you that's caused this. It's not the surgery, the surgeon that's caused this, but it's a side effect of having surgery. There's little incisions on the cornea, the drops they use. We'll go through this later, but these little things will cause them to have dry eye after surgery. The study found is that you do have to manage and treat the dry eye disease. In the NHS, these patients will have their cataract surgery, and more often than not, they're sent back to the community. And patients will complain. They'll complain of poor vision, or their eyes feel gritty, or they feel sore, and you'll think something's happened with the cataract surgery, something's going on, there's inflammation in the eye, they're not seeing because there must be something seriously wrong. It just could be that they're now tipped over to symptomatic dry eye, and dry eye can have a huge impact on their quality of vision. The studies show that the dry eye peaked around 1 day. It makes sense, they've just had surgery, but it persisted between 1 to 12 months. So that's quite a long time. You've just had your surgery. Patients expect they can see really well. I have my cataracts done, it'll be great. I'll be able to see everything. I won't have any issues. I might not even need to wear glasses afterwards. Fantastic. And actually what you get is a very different story. You get them back in your chair complaining that they can't see that well, or their eyes are really sore now. And you have to manage that, because in the NHS, actually the surgeons will have very little time to address this. And I think they are now becoming more dependent on us as optometrists to manage this in our seat, really. So whenever I listen to a webinar or I go to a lecture, I always feel I should just come away with a couple of pearls. if I walk away and I've learned 2 things, I think, well, that was well worth. So hopefully by the end of this, you'll have got your pearls and you'll think that was well worth listening to. The first pearl is prep your patient when you send them for cataract surgery for the best outcomes. And I'm going to show you exactly why you should prep your patients. So dry eye can affect the accuracy and reliability of measurements. And that's the barometry, refraction, and topography. And for those of you that don't understand what happens when you refer a patient for cataract surgery, I'll take you through the process so you'll understand why this all matters. So dry eye can affect the post-operative visual outcomes, including refractive surprise. Roz, did you know that a dry eye patient, a patient with ocular surface disease, can induce 2 diopters of power incorrectly just because they've got dry eye?
I actually do know that, and it's only because when I first started doing a dry eye clinic years ago, and I think actually one of the delegates on here was with me in clinic that day, and we had to do a recheck, and I happened to do some dry eye treatment before he went in for the recheck, and we came out with a completely different result, and it was quite alarming. And it suddenly, I mean, we found that our recheck rates dropped quite a bit, and our remakes therefore dropped quite a bit. So irrespective of what we're talking about here going into cataract surgery, which is way more critical because you can't just redo the surgery, you can remake glasses, and as a business that's expensive, but it's quite phenomenal, right? 60% of our refractive error comes from the front surface, but how often do we really think about that in real terms? That's effectively what you're saying.
Exactly. So everything I'm saying in terms of cataract surgery also affects your refractions, right? So if you've got a recheck, the first thing I'll do is make sure the ocular surface is fine before you then remake glasses for sure. And we'll discuss how this affects post-operative patient satisfaction and the different devices that we use at OCL Vision to just make sure that all the measurements that we have are completely accurate, because like you said, we can't remake. Well, you can remove IOLs and replace them, but the surgeons definitely do not want to do that. So if you're referring a patient for cataract surgery, when they go to the NHS, what they will have is a barometry. They sit a machine on a barometer, and the barometry will take these readings. And if we never saw a patient, if the surgeon had never met the patient, actually from this one test alone, you could decide which power of lens goes into the eye. Ross, did you know that that's just the barometry and that's all they need?
Yeah, I did know that. I still find it quite amazing, but yes, I did know that. And I think it's really important actually as well to know these things, even though you're not going to be doing them, because it's like you said, Purvi, it's about making sure that the patient kind of goes in understanding a little bit what to expect. You're helping to manage their expectations. And that's really important when we're talking about the quality of life issues that we're dealing with here. Yeah, exactly. Sorry, carry on. Sorry.
They have this barometry, and they also, if you come to OCL Vision or elsewhere, they also have a tomography. So what this pentacam does, the one on the right-hand side shows the corneal astigmatism, and the one on the right-hand side, these are little maps, and the one on the left-hand side, the barometry shows the axial length, how long the eye is, the curvature of the cornea, the K readings, and with that, you decide what power of lens goes into the eye. So, for example, with this patient's right eye, if you wanted to choose this particular lens, you'd put an 11 diopter power lens in, and that's what they do. They also then look at the astigmatism. That's a corneal astigmatism. Now, remember, when you're sending a patient for cataract surgery, that lens is coming out. Astigmatism is made up of corneal and lenticular, right? And that's what makes up our glasses prescription, our contact lens prescription, the mixture of the corneal and lenticular. When someone's having cataract surgery, the lens is coming out. It doesn't matter what the lenticular astigmatism is, the lens is coming out, but we need to know what's left on the cornea. So as I just highlighted, the astigmatism on this patient's cornea, 2.16 in the right eye, about 2.5 diopters in the left eye, that's staying on the eye. So for this kind of patient, very similar to a contact lens, you would correct that astigmatism. You're not going to leave a patient 2.5 diopters uncorrected in their glasses or in a contact lens. So likewise, when you're putting an IOL, an intraocular lens, in the eye to replace your own lens, you would correct the astigmatism. And then the topography, that's the corneal astigmatism only, and we're just tallying up that the two scans show exactly the same amount of corneal astigmatism. And that's the element that can change dramatically when you have ocular surface disease. So as you can see here, that's the barometry. This patient's got about 2 diopters, 2.5 diopters right and left. We've done the topography, and actually there you go, that tallies up. and that matches. It's never going to be exactly the same. There's two different machines. We know that when you blink, your tear will change. And you can see this, you know, there are subtle changes between the two eyes, but generally it tallies up. Ros, does that make sense to you?
Yeah, that makes sense. Yeah,
Okay.
absolutely.
So this tallies up. For this patient, we would use a toric IOL. Likewise, if you were giving a contact lens, Ros, you'd correct the astigmatism, right?
Absolutely.
Same thing, intraocular lens, you correct the astigmatism. So for this patient, for example, the corneal astigmatism is 0.3. That's what's going to be remaining. Personally, if I had a patient I was giving a contact lens, I wouldn't give a toric lens. Ros, you're in agreement with that?
Yes, I'm in agreement with
Yeah,
that.
you correct it in glasses because of course you would, but in a contact lens, you probably wouldn't. And likewise, you do the tomography. Look, that's very similar. So for this patient, they can have an IOL that is non-toric. So we just won't correct the astigmatism. And that's how they decide. That's how the surgeon will decide what power of lens goes into the eye, the type of lens they have, trifocals, EDOFs. That all depends on the conversation they have, but generally the power is decided from the biometry and the topography. So remember, prep your patient when you send them for surgery for the best outcomes, and this is why. So this patient, first visit to us. So we did the biometry. If we wanted to aim for 0, plano, so we want them to have perfect distance vision. In the right eye, we put a 23 diopter lens. In the left eye, we put a 23.5 diopter lens. Now, this patient had dry eye. So what we did was we treated the dry eye and then we brought them back for repeat scans. Nothing else has changed in that patient. Their eye isn't suddenly going to go longer. They're not suddenly going to have any huge changes on their corneal surface. So nothing else has changed. All we've done is treat their dry eye. Visit 2 after we treated them. So remember, in the right eye, we were going to do 23. If we chose the 23 now, we'd be leaving about minus 0.4. So that's almost half a diopter difference just because we've treated their dry eye. And if you look at the left eye, 23.5 is what would have got them closest to being 0 in the distance. If we put a 23.5 in their eye, they would have come out as almost minus 0.7. And if you're aiming for plano, you want to give someone good distance vision. And just by treating the ocular surface, Ros, can you see the difference in the outcome?
Yeah, that's actually quite alarming, isn't it? And if you think about who you're going to actually end up with in your chair at the end of this surgery, it's going to be quite something. It's going to be in my chair.
And
that's the reality.
Let's be honest, a minus 0.7, you might not be as unhappy, but it can also go the other way.
Yeah.
It could come up plus 0.7. Look, no one really wants to be a plus 1 diopter after cataract surgery. Or at least with a bit of minus, you've got some help with the intermediate, but a plus 1, that would be awful. That's a terrible outcome. So, and all we have done here is address the ocular surface. We've treated dry eye. So that's the kind of implications you can have. And as we'll go on, I'll show you some real life cases of what's happened. This is actually one of our patients. This was her right eye. And you can see the corneal astigmatism is 0.1. Now, I wouldn't toric that, 0.1 diopter. Ros, you agree, right? There's no need to toric that. But she had dry eye. So we treated a dry eye. We brought her back. Look how much astigmatism she actually has.
Yeah, that's a little bit more worry, isn't it? Yeah.
That would have been missed. Post-surgery, she would have come up with 1.5 diopters of SIL uncorrected. Now, these are 2 different readings, and obviously they're very different. We wouldn't just go by the second reading. What you then would do, continue to treat her dry eye and make sure this is stable. We want a stable tear film, so we make sure this is repeatable, but you can see the huge difference that you can get just by treating the ocular surface. Left eye, this is the same patient, left eye pre, 0.7 diopters. We treat the ocular surface, boom, 2 diopters of corneal astigmatism there. That was being masked by an unstable tear film. That's a big difference. And that patient could end up in your chair with 2 diopters of SIL, and they're not going to be happy. And the thing is, you could prevent things like this. So a real life case, this is case 1. We've got a 79-year-old female. She's been told she's got cataracts. This is what she comes in with. So actually, her vision's okay. So best corrected, she's 6.7.5. Best corrected, she's N5 for reading. She's had a Bell's palsy 40 years ago. So we know that this can affect the structure of her eyelids, the position in which her lid margins sit, her tear quality, how the tears produced. So we know that she's likely going to have dry eye and a tear surface that needs some seeing to. So these were her measurements. Again, we did the biometry and we did the topography. So the biometry says half diopter of SIL. the topography, look, there's a red flag there. It's saying this isn't a very accurate reading. It correlates, maybe not that much. 0.37 again with the left eye on the biometry. Yeah, the topography is saying 0.7. And because there were such small amounts of astigmatism, we didn't think we were going to correct it. So perhaps we didn't pay as much attention to it because it was just a very low amount of SIL, and both were generally a little bit low that we thought she won't need a toric. This is her post-op review. So she's 6:15 unaided. Roz, would you be happy with a 6:15 unaided?
No.
No.
Yeah, I am. So I'm shaking my head. I just realised you couldn't see me. No.
So
no. Beg your pardon. No.
Unaided, right? That's how
She's
she's
not good.
Not good. We've repeated the topography scans because by this point we'd obviously treated her ocular surface, thinking maybe her eyes they were very dry. Post-op, she had 1.2 diopters of astigmatism. That's with her dry eye treated. Compared to pre-op, we found a 0.1. Again, in that left eye, she had 1.9 diopters of astigmatism uncorrected, compared to the pre-op, where we'd only found 0.7. So her having now treated her dry eye because of the post-operative drops and everything we'd done just to make sure she was happy because she was so unhappy with her vision, has unmasked this astigmatism. And actually, when we did the refraction, there it is, right in the refraction as well. You've got that same amount of astigmatism sitting there on that cornea. Now, look, cataract surgery can induce, poor cataract surgery can induce astigmatism if you're making much larger incisions than you should be. But our surgeons are pretty good. And look, the surgeries nowadays is so fantastic with the tools and the injectors that they use, that you cannot put that much amount of astigmatism onto the cornea with any incisions you make. So that was just unmasked dryness. So what do we do now? So you have an option. What you can do in the cataracts is you can either laser a patient or you can put a piggyback lens, so another lens over the original IOL to correct that prescription. Laser will make the eye dry, we know that. So we thoroughly treated her dry eye. We treated the ocular surface with artificial tears. We also gave a Softacort. So Softacort is a really mild steroid. It's a corticosteroid, but it doesn't penetrate so deeply into the eye. It's very surface acting. So what it does, it reduces the inflammation on the ocular surface. We know inflammation is a huge driver of ocular surface disease. It's a vicious cycle. So we did put her on some Softacort. We decided not to plug. When you've got a patient with a very inflamed ocular surface and dry eye, my feeling is that plugging the punctum isn't a good idea, because all they're doing then is sitting with these inflamed tears on their ocular surface. Roz, how do you feel about plugging for these?
I do use plugs quite a bit, but I absolutely make sure that the inflammation is at a lower level before we start doing that, because you just don't want to destabilize that. You don't want to harm the ocular surface and make it even more unhappy, if you like.
No, exactly.
So absolutely that. Exactly that.
We did do a ZEST treatment, and I'm sure you'll talk a little bit about the ZEST later on, but for those that you don't know, actually we do use ZEST a lot at OCL, and one of our surgeons sends a lot of his patients for a ZEST preoperatively. We don't actually charge them, we just include them as part of that package. They may well have a ZEST just to really treat the eyelid margins, reduce the inflammation, help if there's any Demodex there. And just generally helps improve the ocular surface and results in a much more stable tear film before they have their biometry and topography done. And we will also recommend supplements for them to take. So fish oils, omega, if they're vegan, we suggest vegan supplements such as flaxseed oil or types of oils that are suitable for vegans. And we do IPL as well. So just really unblocking those meibomian glands, getting the meibum out onto the ocular surface and just making it a lot more stable. And then we watched her. So 2 months post-op, we refracted her. 4 months post-op, we refracted her. 5 months and 6 months. And actually what we found out that she was stable. So at that point, her prescription was very much stable, and we knew that we could treat her. And because we treated her ocular surface, her tear breakup was really good and her ocular surface was fantastic. That actually we did manage to laser her. So 4 months post-laser, that was the outcome. She was delighted at this point. Obviously, 4 months post what she had expected, but she was 6'5", unaided, but we could have prevented all of this, to be fair, beforehand if we just really had addressed it. And actually, this was very, very early on, before we really before we really got into what we should be doing in terms of these patients where you're not sure, just because they have a low amount of astigmatism, let's not assume that this is their true prescription, their true corneal astigmatic elements, and let's really ensure that this is, especially if we find their tear breakup's poor, let's just bring them back in to repeat the scans and make sure. So take home message, well, for me for sure, is check the topography for accurate scans, optimize the ocular surface. So case number 2, this lady was a 54-year-old female, so that the age element is quite important actually. She wants to be spec-free, so she wants to be completely spectacle independent. Her health is good, she's on HRT, so we know that she's menopausal, going through the menopause, and we know that can have changes on the ocular surface. She wears varifocals all the time and she has no contact lenses. Occasionally uses artificial tears, so she's aware that her eyes are a little bit dry, but she's not so dependent on them. She's actually got really good vision to begin with. She's 6'6", unaided in the distance. Her near vision has dropped, so it's the N12. It's that she's just a presbyope, and she's really unhappy now having to wear glasses all the time. And they're the more difficult patients to treat anyway, because their distance is so good. You're not really enhancing their distance, and their near, you're mainly just enhancing their near vision. So her tear breakup is poor, so it is less than 5 seconds. So we know that her tear film isn't as stable as it should be. 2 weeks post-op, she's really unhappy with her vision. Her eyes feel heavy and tired. She's suffering with a lot of glare. Clarity has been lost. These are her vision. She's 6'6" N4. Ross, does that surprise you? That's what her vision outcome
Yeah,
is?
I mean, I'm just surprised. I mean, I was not expecting her to be seeing that well, but what we're talking about here now is quality of life and what she's expecting, right? That's really where we're going with this.
Exactly.
And it's interesting that she's at that age where she is in menopause, and we know what that does to the tear film, right? We're starting to have more of an understanding of that as well. So a lot of things are actually going on in my head right now, but sorry, I'll let you carry on, Purvi. Sorry for rattling on.
No, I like you rattling on. So actually what this shows is, this is for her, it's not quantity of vision, it's a quality of vision. And actually that's the most important thing. I will always say go for quality of vision, not quantity. So she has 6'6" and she's N4. She is on paper completely spectacle independent, but she's really miserable. She might have the quantity, but she definitely doesn't have the quality. So we all know when we're testing patients in our chart, we've got black on white. You can dim the contrast if you've got some tests like that, but it's a stable object. Nothing's moving around you. It's black and white. The room is well lit. It's a very false setting. Out in the real world, the contrast isn't black and white. Things are moving, you know. There's different humidities, there's air moving around, there's a lot of things going on, a lot of unknowns going on. And she was really, really miserable. Despite that, 1 month post-op, so actually what she said was, on a good day, eyes are fine, doesn't feel the eyes as much, her eyes don't water, and on a bad day, her eyes are very watery and sore, and she's aware of them. So we know things are fluctuating. When your vision's fluctuating and how you feel fluctuates, we know that that's your tear film. That's why you're getting such fluctuations in the vision. If it was anything else inside the eye, we know that would generally stay more stable. So anything that fluctuates, to me, resonates with fluctuating vision. We know that's an unstable tear film going on. She's using the Optomel and Hydromed. Optomel, I'm sure, Ros, you'll talk about a little bit about that later. We tend to save that for patients who can't really get on with sodium hyaluronate drops, or whichever ones you're choosing to give to them. The clarity is missing and affected by light. So she's got a trifocal lens in her eye. So for those of you that don't know how a trifocal lens works, it has got, if you ever looked in an eye, I'm not sure if many of you have seen it in an eye, hopefully a few of you have actually, they're quite common these days in the private sector, but they have rings. So when you look at the slit lamp and you put the light straight through the middle, you will actually see little rings. And what those rings do is it splits light. And that gives you the ability to see at distance, intermediate and near, and actually 3 very clear zones. You'll have a great point at distance, there'll be a middle point at intermediate, and then there'll be another range at near, and it's 3 quite distinct points. But the downside of that kind of lens, it does split light. So as we know, we need all the light to hit the back of the eye. And with diffractive optics, you can lose up to about 15% of the light. So in dimmer light levels, your quality of vision might not be there, and you do get some contrast sensitivity loss. So if you've already got that going on, and then your tear film is unstable and it's causing a lot of light scatter, you're then losing light from the moment it even hits your eye, let alone what it does inside the eye. You will end up with quality of vision issues. And that's what was happening with her. The thing I circled is quite interesting, actually. So when someone comes in and I know that they've seen 6.6 before, or they've seen 6.5 before, and today they're at 6.9, 6.7.5. There's nothing else I can see that's causing that. I'll often pop in a drop of saline, and it's very temporary, but I'll pop it in, ask them to blink a few times, and just say, look, temporarily, can you read any more? And they say, oh yes, it's cleared up. I can read. And then, you know what, within 10 seconds, not even that, it will then go. But you know, by regulating their tear film, actually you've made them achieve that 6.6 vision. Ros, is that anything that you use in practice? Have you ever popped a drop to saline in just to see what happens to the vision?
Yeah, absolutely. I mean, we actually used to do this thing where we used to put drops, because where I used to work in Fleet Street is very, very lawyer heavy based, if you like, and everybody used to come in, and even when they're sitting in your waiting room, they're kind of like on their phones, they're looking at documents or whatever. So we used to actually put a little bit of an artificial tearing just before they went in for the test, and even went in for their scans, just to stabilize everything a bit.
Yeah.
And you know, it works absolutely, because you've got to remember that front surface, that tear film, is the interface between your cornea and the outside world, and it is responsible for that front surface. Is 60% of your refractive error. 20% of that is made up of the tear film. That's a huge number.
Yeah.
So that instability is going to really have quite an effect, without a doubt. So what we're talking about isn't anything new or revolutionary. We're just actually going back to basics, aren't we? But I'll let you carry on, Purvi.
This is what we found when we stained her. So you can see why she's very unhappy. Look, just from that picture, you can see that no wonder she's miserable. You know, that's a very unstable tear film just there. 14th visit post-op. That's how many times she sat in my chair. And actually, she was really unhappy for most of them. This is how I felt half the time, because we always refracted her to make sure. When you've got a poor tear film, you know, one or two, I don't know if you've ever tried to do a refraction for a sill, and they're just going round and round. There's no endpoint. And you know, when there's no endpoint, either they're really bad at subjective, which isn't that often, or they can't find an endpoint because their tears are just changing every time, that there is no endpoint for them. But actually, we did get her there in the end. We got her to a place where she was happier. And a little study just here shows that in 2016, the common causes of dissatisfaction after cataract surgery, 60% was residual refractive error. Fair enough. If you've been left at +1, you're going to be a bit miserable. But actually, a third of patients claimed dry eye disease was the main reason that they were really unhappy after their surgery, which is a shame. If they can see, but their dry eyes hindering their quality of life and quality of vision. So what did we do in those 14 visits? A lot of counselling. I mean, I find you end up doing a lot of talking with these patients, trying to get them to understand what's going on. It sometimes gives you more control when you know why things are happening the way they are. In-house and at-home treatments. We had a discussion about her menopause. So I know, Ros, you talked about the menopause and how this affects women. And you're right, there's a lot of talk going on right now about menopause and ocular surface disease. And I won't go into this right now, because I'll be honest, this isn't quite my area of expertise here, but we know that it's the androgens and the estrogen and progesterone. And actually, you will read lots of different studies which will tell you the estrogen and progesterone are quite good, but actually also they can have quite a negative effect on your glands. The androgens, the testosterone, that has quite a positive impact, but then you might read a study that says actually it can also have a negative impact. So I don't think it's quite been found out really the true mechanism behind the menopause and ocular surface disease, which hormones are called, which androgens are causing what. But there is a lot of research going out there at the moment. And studies do show that there is a link between women and dry eye. Hence, you know, our hormones are where we're made up, the menopause and the dry eye, and also lens-based surgery in dry eye. So my poor patient had all three of them that she was dealing with, plus a multifocal lens in her eye, which isn't so forgiving when you've got a poor ocular surface. Ross, did you want to expand on the menopause? But I think you probably know a little bit more about it, actually.
Yeah, I mean, it's quite, I mean, you're absolutely right. There's a lot of conflicting information out there. I've been reading about it quite a lot. And there's a point that was just made a moment ago by, I think it was Irfan. It's not just women, right? I mean, it hits women hard, but actually men's hormones change as well. Just it's not quite a drop off the edge of a cliff that women face, right?
Yeah.
But for sure, there is a difference in output, you know, the tear stability, the quality of the tear you're producing, the quantity of the tear you're producing. And that's why we're seeing a lot more. And I can tell you for sure, that's why why are we finding that suddenly somebody's been wearing a contact lens quite successfully, for a number of years, nothing really has changed on the front surface of their eye, and suddenly they can't tolerate this lens and it's uncomfortable and they have to take it out because it's drying. So the only thing that can have possibly changed, because the lens sure as hell hasn't, is the quality of the tears, and it happens to coincide with their environment is still the same, everything else is still the same. It's actually their chemistry that's altered. And that's generally, I'm seeing that as a contact lens optician, mid-40s to, you know, early 50s for women especially, that's going on. And yes, we've got the presbyopia part hitting that as well. So there's a lot of things going on, but I can tell when I'm looking at the tear film that things are altering. You know, I can just tell the quality is altered. So, Purvi, I could talk about this for ages. So I'm going to come back to you, and we'll talk a little bit later, hopefully at the end of the session.
So actually, this patient has now been tipped from asymptomatic to, or mildly symptomatic, only needing artificial tears twice a day, to symptomatic. So she was already tinkering on symptomatic dry eye, but actually the process of having the surgery has now tipped her way over to symptomatic, and it did really affect her vision and how she was feeling. So we just need to know that we need to manage these patients, explain to them what could happen. Also, we need to look out for this. So one of our things is, if we see poor ocular surface and dry eye disease, we won't give diffractive optics in patients, because we know they don't enjoy the quality of vision that comes with it afterwards. So there's a lot of things that you have to look, and so the ocular surface is the first place that you should start, just to, when you're even thinking about what kind of lens would suit this patient. So the benefits of optimizing the ocular surface pre-op. This is an 81-year-old female. She's been told she's got cataracts. Otherwise, she's absolutely fine. She only wants complete spectacle independence. There was no other option for her. That was it. I either want trifocals or I want nothing, because I don't want to have to wear glasses. Now, patients don't often hold our surgeons to ransom. They'll say, this is what I will do for you, and that's all. If you want something else and I don't agree, you could see somebody else. And that's absolutely fine. You have to, you know, work within what you feel comfortable with. But this lady, when we looked at her, so actually, if you look at her vision, she had pretty good vision, corrected. She was 6'9", N5 binocular, best corrected. So that's pretty good, actually. It's not too terrible. Nice and healthy macula. The only other thing that would make you think, let's not trifocal this lady, is maybe the macula's not so healthy and not quite so pristine. But actually, hers was absolutely fantastic. A really good macula. And the initial scans, you know, we did the biometry, half a diopter of still, the right eye, 0.8, a little bit more. So if you're just going with the biometry, you perhaps wouldn't correct the astigmatism. If you're then looking at the topography, you probably would correct the astigmatism. So you're already thinking, the left eye, 0.8 diopters, the right eye, the left eye tomography is similar, 0.9 diopters. But there's a small amount of discrepancy there. But tear breakup time was 4 seconds and had a poor ocular surface. So what do we do for this lady? And sorry, this was her. When you have a blink, you can have a little look, and Roz, I'm sure you can see a bit of SVK at the bottom there. You can see the tears breaking up. Yeah. You know, so not horrendous, not pristine. So how do we treat this? There's various things you can do. Artificial tears, warm compress, dietary advice. They're the three most basic things we could tell anybody to do, and things that they could do at home, and things that will help them. We're not telling them to use artificial tears for the rest of their life. What we're saying is, if you want to consider this, we have to optimize your ocular surface, and it will mean you'll have to use artificial tears to get your tear film more stable. You'd have to do a warm compress. Now, we know with a warm compress, the impact it has. It is helpful though. You know, anything is better than nothing. And we are asking her to just try and relieve those blockages, get the myelin coming out a little bit better. And we gave her dietary advice. You know, you're talking about taking flaxseed oil and watching what she's having in her diet. Other things you can do, mild steroids, we talked about the softer cords, and also what the patients want. So you can do IPL, you can do Zest, you can give gels, and you can give drugs. You know, you can give other things to help the patient. We'll come to those later, but the simple things you can do that anyone could send their patient at home to take them home is artificial tears, warm compress, and dietary advice. If any of you are sending patients onto the NHS to have cataract surgery done, whether their tear film is great or whether their tear film is awful, these are the three things I would advise you to tell your patients to do. I would say, I'm going to refer you for cataract surgery. If you're lucky, you'll be seen hopefully in 3 months. I don't know how bad the waiting lists are now, but I think with the opening of other clinics, Czech and Optegra and other NHS contracts, actually the waiting list is not too bad these days. But start taking these artificial tears, use them 3 times a day. The ones you give them, we'll come to that. a warm compress. You need to do a warm compress every day or do it every 2 days. Don't give them a limit they can't achieve. Don't say, I need you to do a warm compress twice a day, or I need you to do it every day. They'll give up. You know, if you say, do it 2 or 3 times a week, it's better than none. If you can do it 4 times a week, great. Make it achievable for them. And then give dietary advice. Just say, start taking some omega. We know omega-3/6 is really good in good balance with the DHA and EPA. So have one that you recommend and say, start taking this. And then go. That way their eyes are prepped. You know, their eyes are prepped. When they sit in front of that barometer, when they go to the NHS, they probably won't be having a pentacam. They won't be having a separate topography just to make sure all the scans are aligning. What they will do is they'll go in and they'll have a barometry, and that's all they will have. So we need to make sure that that scan is absolutely as good as it can be for their best output. And this is what I would tell all my patients what I do. When you have surgery, just start doing this now, or when you get that appointment through, the moment you get that appointment through, you know it's in 2 weeks or 3 weeks, start prepping your tear film. So how did we treat this lady? We did give her a daily warm compress, and actually this is the warm compress that we give all our inpatients. We do have a preference for this one. I'm sure Roz will take you through the benefits of it. This is one that we give ours. Actually, it's not branded, ours is branded. That's an image I took. Preservative-free sodium hyaluronate, or you could give something more specific, some lipid replacement, depending on what drops you prefer to use. We have a range that we like to give, and we'll talk about which drops you like to give. It's a personal preference. And we did treat her with FML once a day in both eyes. So FML is similar to Softical. It's a very mild steroid. It's surface acting to reduce inflammation. It does have a preservative in it. Ideally, I avoid anything with preservatives. However, she was using it once a day. So we felt to just give her a bottle of that was absolutely fine. Alternatively, you could give a Softical, but we actually gave FMR to this lady. And we followed her up 6 weeks later. And actually, her still had gone up a little bit to 0.67, and it correlated 0.7. We did actually give a toric lens, a trifocal in that eye. Trifocal lenses aren't so forgiving when you've got residual astigmatism, so we do correct all of the astigmatism. But even if we're going to leave about 0.7, we generally correct it. And in the left eye, there's a little bit more sil that was picked up this time, and the scan has correlated enough. More importantly, her tear breakup time had increased. Her ocular surface looked better, so we knew that this was a much more stable tear film. 2 weeks post-surgery, actually the patient was travelling back, was back home, so we didn't see her after this, but she was still using medicated eye drops at this point, so it's very, very early post-op. But actually, she's 6'6" and then 5 unaided, so she was absolutely delighted. And had we not given her time to treat the ocular surface, we could have said you can only have monofocals. And actually, had we treated her and she had still come back with a poor tear breakup time and not a good, we probably would have given her monofocal or an EDOF, you know, an extended depth of focus, which can tolerate a poor ocular surface or a not so great ocular surface. But we actually got to a point where she could have trifocals and she was really happy. Was any thoughts on that case?
Yeah, I just think it's quite incredible to show just what a little bit of, I mean, I'm sure everybody on this call has probably got an eye bag at home sitting in their drawer, right? And how often do we use it? But actually a little bit of prep pre-surgery makes such a difference. And if we think about that whole baby shampoo thing, right, that's actually where it started from, wasn't it? It was actually about treating the front surface before you went in for surgery. That's where it was. So this isn't anything new. We can just do it in a much better way and with a lot more sophistication and understanding.
And there's a
reason, rightly so.
Yeah. Sorry, Roz.
Yeah, absolutely. Carry on. Yeah, please.
This is a great case, and actually this is a really heartwarming case, and I hope you guys feel the same. I know a couple of my team are on this webinar actually. I know this case makes them feel really good. This was a 48-year-old male. Lovely chap. He had a brainstem injury when he was 18, so he was a quadriplegic. He used to come in with the carers to bring him in an electric wheelchair. It was a great wheelchair actually, and he lived independently, so he was coping really well. He's now become presbyopic, you know, and that changes things a lot when you're presbyopic and you can't move your arms. He didn't tolerate varifocals, so ordinarily you think, you know what, you could prescribe him a pair of varifocals and at least he can read and see the distance and he'll be fine. Didn't tolerate them, so he couldn't. So when he had his distance glasses on, he couldn't read, and he couldn't put reading glasses on when he wanted to do things. So he does need unaided distance and near vision. So when he came in, these were his vision. So he was 7.5. His distance wasn't too bad. His near was about N6, you know, and it was getting worse. And you can see with his prescription there why it was getting worse. He was hypermetropic. You know, he was now becoming presbyopic, and you know that would have changed very quickly. Actually, that N6 I did would have quickly dropped to N12, N14 before he knew it, and he was already finding things were very difficult. The only real long-term option is lens-based surgery. Obviously no contact lenses, you can't put them in and take them out. He didn't really tolerate an isometropia very well, so the only option for him was trifocals. That's the only thing that would render him spectacle independent. This was his presentation. Ross, do you have any thoughts on this?
Yeah, I can see straight away we've got some Demodex there, haven't we?
Yeah.
Absolutely, and we really need to clear that up before, and the misdirected lashes, the lids are quite red as well. Yeah, absolutely.
Exactly. And then he's got, obviously you can see the telangiectasia on the eyelid margins.
Yeah.
On the second picture, you've got the abnormal blood vessels there. And so for those of you that don't know, patients that often have rosacea often end up with telangiectasia along their eyelid margins. He did actually have rosacea, this chap. So he's got these little abnormal blood vessels on his eyelid margin, and what they do is they drive inflammation to the glands. When you drive inflammation to the glands, it makes your glands not produce meibum, it gets them blocked, and you just essentially, there's no meibum being produced out of those glands, and his tear film is very inflamed. And we know that's going to be a very unstable tear film. And you've already seen when you put a trifocal or diffractive optics, the ones with the rings, in a patient that's got an unstable tear film, the quality of vision will not be great. And we don't really want to bring this chap back into theatre to have to take some lenses out. We just kind of need to nail this in one go. So the plan for him was we actually carried out a zest, just to really speed things up. Zest is good with Demodex. There are other things I'll talk about that you can use with Demodex, but we did do a zest treatment. It's instantaneous. You'll clear that. The Demodex, obviously the cycle's longer, so you won't just clear the Demodex in one sitting, but we did carry out a zest. We then booked him for IPL treatments. Now we couldn't bring the slit lamp up and get him into a chair to put him in the slit lamp every time we saw him. We do have a portable slit lamp that we could get to him, that we needed to when we took these pictures and whatnot. But it's not practical for us to have to move him to want to be moved. So actually I did Demodex, I did IPL in his wheelchair, and my colleague also did IPL in his wheelchair, and we did lid squeezing without a slit lamp. You kind of make do, and he was a really compliant patient. We also prescribed in post-IPL is limacycline, so 408 milligrams, 1 tablet a day for rosacea. We don't give limacycline whilst we're doing IPL. So those of you that do IPL will know that IPL makes you more photosensitive, so your skin will be more reactive to the sun. Limacycline, which is an oral medication, also has the same effect, so makes you more photosensitive. So the last thing you want to do is to make him more photosensitive and then give him IPL, then send him out. So we started a course of limacycline after, which is very good for rosacea patients. And this isn't him, actually, this is our CEO having a zest treatment before his IOL surgery. And I'm going to hit play. It is in fast forward. So Ross, don't judge my technique. This is fast forward, right? I don't just go really, really quickly. But how's the technique looking?
It's all right. It's
all
okay.
right.
You're doing good. Yeah, you're doing hey, come and see you. No, actually, I do. Actually, that's really good. You see how the swab is going up through the lashes, almost like a mascara brush. That's really important because that really cleans the lashes, especially if you've got the time that that flaky blepharitis, the seborrheic blepharitis that really affects the lashes. It's really, really good for that. And you have very clean lashes. The base gets really, really cleaned out as well. It's a really nice debriding treatment. Really helps to bring the inflammation down on those tange glands, as I call them to my patients, and the eye just feels a lot more comfortable straight away. And I'll go into the mechanism behind that in a while, but you can see straight here that it's actually very easy to do and very comfortable for the patient as well. And I think that's the most important thing. Would you not say, Purvi?
Definitely. I love it because actually patients, we used to do Blefex a lot. So that's the only lid exfoliation we had. We used to do a Blefex. The Blefex definitely has its place for sure.
Definitely.
But the patients prefer zest.
It's the comfort, right? I mean, they're both debriding pieces of kit, but I think the zest just steps in a bit more because it's got that anti-inflammatory agent to it as well.
Exactly. They straight away, they feel their eyes are cooler. They just feel nicer.
Yeah, absolutely. That's what I'm getting in practice as well a lot. So, but we'll talk about that. And that's absolutely the difference. And the interesting thing to see there on that imaging as well is if you look at those red inflammatory vessels, they're just a bit calmer.
Yeah,
Right,
exactly.
on the other side. So that shows you how the inflammation has been brought down. I almost think about Zest like giving your eye a localized ibuprofen. That's how I explain it, you know, and it's basically exactly that. But again, I digress. I'll let you carry on, Purvi.
Great way of explaining it, actually, a localized ibuprofen just to calm all the inflammation down. So you can see straight away the impact that a Zest has. So this chap never returned for his follow-ups. Now, when a patient doesn't come back for a follow-up, you will call them. And he didn't come back, and generally it's because they're happy. Sorry, no, this was his follow-up 2 months later before he had surgery. So we did the barometry, 1 diopter of SIL, we did the topography, 1 diopter of SIL, left eye, 1 diopter, right eye, 0.8. So we know this is all tallying up. He had toric trifocals, and he didn't come back for his post-op. So this was 16 months later when he eventually returned. So that's when we managed to check his vision, and he was 6.6 and 5, but he returned because his vision was variable again. So what we found when we examined him was that the blepharitis had returned. So we repeated the Zest, and it also booked him in for IPL top-up. So, but his vision, and he'd been happy all this time, you know. He was so happy because he's gone from not being able to live, you know, it's very difficult for him to have lived his normal life without the fact that he now can't read very well. And so now we've just transformed his life, and this was just a great story. But again, another one, nothing lasts forever. You know, if your tear film's unstable, it's stable. It's unstable. The Demodex will come back. The Blef will come back, and you do have to top up IPL. So we often do 4 to 6. I'm now more heading towards 6. So 6 blocks every 2 to 3 weeks, 6 sessions as your first block. And then I tend to say to patients, come and see me once every 6 months for a top up. Most patients after the first block of 6 will come back probably at about 3 to 4 months to say, I think I need a top up. But our aim will always be to see them back every 6 months for a top up if they can last. And most of them can. After they've had those little top ups, they then tend to last every 6 months before they need another one. This is just a nice little video about, I mean, I use Q-tips to express sterile Q-tips that come out of a packet. I just like the feel of how much I'm squeezing, but there are better bits of equipment out there. That's pre-IPL. You can see the quality of the meibum that's coming out and how it's quite poor and difficult to express. And just post-op, you know, post-IPL, you can just see it comes out a little bit, you know, a little bit easier. Ross, do you like a little bit of eyelid squeezing?
Oh yes, it's a must. I mean, to be honest with you, you can't really examine the front surface eye without doing it, right? Because you're looking for that non-obvious MGD. You're looking for when the glands are starting to fail. It's going to happen because those meibomian glands are very susceptible to that. So, you know, even if everything looks good, give it a bit of a push and see what's going on.
Exactly. Now, some of the reasons why patients get post-operative dry eye is during the procedure itself. That they're sitting, they've got anaesthetic in their eyes, and they're holding their eyes open like this. They don't have a need to blink because they can't feel anything. So they're sitting like this for 10-15 minutes until they get called in, and they haven't been blinking. Before they've even sat and lie down onto that desk, onto that theatre bed, their eyes are completely dry. You know, then you've got the speculum that holds their eye open, so their eyes are exposed a lot. So when you've got exposure, you're going to get evaporation of the tear film. The time it takes for surgery nowadays, it's very quick, about 15 to 20 minutes, probably bilateral, to be honest. It's very quick, but the longer it takes, the more they have their eyes opened, the more energy that's going into their eyes if you've got dense cataracts. Phototoxicity, there's evidence that shows that the light that they use during the surgery can have a toxic effect on the ocular surface. The environment they're in, theatre rooms are generally pretty cool, actually. So when you've got cool and you've got some moving air, you're going to get more evaporation of the tears. The drops they use during the procedure, you know, they're putting iodine, whatever the drops they're putting in during the actual procedure, the anaesthetic is all causing issues to the ocular surface. The incisions they make, so I know we're talking about 2mm incisions, but there's still little incisions on that corneal nerves. And you need the corneal nerves to tell your lacrimal gland to produce the tears to prevent, you know, to start that cycle. Any break to that corneal nerve, you sever that nerve, you're just dropping that link to the lacrimal gland to tell it to produce the aqueous. LRI, so limbal relaxing incisions. If you're not correcting the astigmatism with a toric intraocular lens, you can often make incisions close to the limbus that just debulks the astigmatism a little bit. I think most people are doing it a little bit less and less now because it doesn't last forever, and we do know it has an impact on dry eye post-operative. So people are heading more towards just correcting even a 0.75 SIL with a toric lens if allowed in the NHS. I think it's over 2 diopters, which they'll correct of corneal astigmatism. In some other areas, if you're lucky, they'll correct less, but generally it's about 2 diopters. In the private sector, obviously we can correct whatever we want to, depending on what the patient wishes to pay for. Post-operative, we do give preservative and eye drops. They're on Maxidex and they'll be on chloramphenicol. So chloramphenicol typically for a week, and then Maxidex I'll take on a tapering dose for 4 weeks. And there are preservatives in the Maxidex. We don't give them all preservative-free. Purely environmental factors as well. We don't want to giving everyone these little plastic vials to throw away on a daily basis. Too, there's a cost element as well. You know, these drops are quite expensive. So long term, we just give them the bottle to use. They often, because they're putting lots of drops in their eyes, they're not using their artificial tears as much. They've already got enough things to have to deal with. So even though we give them to them, they don't use them. They've often stopped the warm compress. I'm funny with inflammation and heat. So I often say to patients, don't do a warm compress whilst you're using the steroid, the Maxidex. I don't even know if that's evidence-based, if I'm honest, but there's something with heat. If their eyes are inflamed, I don't often put heat. And this is just a small video from Ali, one of our consultants, of him just doing a cataract procedure. Actually, you can see the speculum, you can see the eyes are completely wide open. So there's a lot of exposure going on there with the tears. You can see the incisions he's made into that cornea. See there's two little incisions there. One's a phaco machine, then you've got the other machine there, and he's breaking up that cataract there, but the eyes are still wide open. You know, there's energy going into the eye to break all that up, taking away, make sure he's getting all the front caps, and then in goes the lens. Eyes are still wide open at this point. So this is actually a more specialist lens. It's called an IC8 lens. Essentially, it's a type of pinhole IOL that you put in for patients that have had previous radial keratotomies. I think you might be able to see the little incisions on the cornea, what they used to do to correct prescription before laser came out. And that you can see all the exposure going on there, which is why patients' eyes get quite dry. So what does this mean for us as optometrists? Why are we here listening to this? So ocular surface, as I've shown, is an integral part of successful refractive and cataract surgery. You need to establish a healthy ocular surface preoperatively to ensure good visual outcomes and comfort outcomes. We as community optometrists, when you're on the high street, we're in the best place to start treatment for these patients. Like I mentioned, when they go to the NHS, they won't have this. They won't have the time to be educated on why they need to treat their ocular surface. They'll have the biometry done. And if they had an unstable tear film, they've already had their biometry done. So it's important that we let them know that when you go in for that appointment, make sure your eyes are prepped, you know, educate them. And they'll establish a much better trust with you because they think, wow, this optometrist is really looking after me. They know what's going to happen. And if they think I need to use these eye drops, I should start using them or do a warm compress or some simple dietary advice. We're not asking, we're not having to see, we don't have to do IPL and Zest and all this extra things. Look, if you explain to them a Zest will help just to give them a little quick boost, then great. You know, that's great, one for business, but really great for their eyes if they can afford it. And it'll give them the best outcome. But patients that are motivated for surgery and are unaware that they have dry eye, so you need to include lots of counselling, and also, you know what the risk factors are. So the patients that are coming in that you're referring for cataract surgery, right, it's going to be the older population, or even if they're wanting a refractive lens exchange. A lot of this is becoming elective now. Patients are choosing to be spectacle free, so they might be you want to be referred privately to have refractive lens exchange. So elective lens exchange. So just know who you've got sitting in front of you. You might have an old lady with MGD sitting in front of you. You know that's a risk factor. They might well still be working on the computer all the day, or they've been wearing contact lenses, they're in successful monovision. Great, they just want to replicate that when they have their cataract surgery. But they're wearing contact lenses, their eyes are going to be dry. Make sure you prep them that. Take your lenses out for at least 2 weeks, maybe a week if they really can't go without. Definitely 2 days if they 100% can't go without for those really high myopes. If they're rigid gas permeable, a lot longer, 2 months. Get that cornea back to its more natural shape before they do any of those biometry scans. And educate them of the environment they're in. If you're going to be spending a long time on the screen, or if you're going anywhere where it's very cold or moving air, just make sure before you're going for a scan you've prepped your eyes. Or if they're smokers or they drink a lot of alcohol, give them advice on what they need to do just to make sure their ocular surface is the best it is before they go in. So my pearl, educate them about getting the best results from the surgery. This patient has waited a long time to be referred maybe for their cataracts. They finally go in, the surgeon sees them and says, we're not doing it today. You've got too much blepharitis. For me, that's a risk of you developing a serious infection after surgery. we're not going to do this. You know, they could be refused surgery. If you've seen this on their eyelid margins, treat it. Take a photo. The best thing I would ever say is take a photo. You don't need a digital slit lamp. If you have one, great. We're very lucky, we're spoiled. We have digital slit lamps. Sometimes they have failed on me at work and I get my phone. Simple phone. Put it up to your eyepiece. Find the best eyepiece to use and just take a snapshot and show them. If someone showed me a picture of this on my eyelashes, I would 100% say, and you'll find a lot of your patients will say, please get rid of this for me. And explain to them why this isn't good for you if you're going to them for cataract surgery, and they'll be really compliant with you, and they will agree with any exfoliation method you suggest, be it in-house where you're delivering the Zest or a BlephX or a new lids, or even something they're doing home, for example, a new lids, or just even a BlephClean wipe, you know, a wipe or anything is better than nothing. So what does this mean for optometrists, opticians? Educate them, offer them in-house and at-home treatments, know what's in your drops. You know, if you know what's exactly in your drops, why am I suggesting this drop for you? Know what's in it. They're going to trust you and they will buy that drop and they will use that drop. They'll see it as medication. If we prescribe them medication, they're definitely going to take it. It's been prescribed. I've got to take it. I've got to follow the regime. If you give them a drop and say, this is what's in your drop, this is why you need to take it, they will treat it like medication and they will take it. And they'll be a lot more compliant than you think they will be. It builds trust. They really feel that you are looking after them. You want the best outcome for them, and we do. That's what we want, the best outcome from them. They trust us, and they'll go and talk to their friends who have seen their other optometrist who's referred them. Oh, I wasn't told to use this, and I say, oh, I was told because of these reasons. And you know, it builds that trust that you really are looking out for them. And the surgeon will be really happy. You know, when you write that referral letter, you can say, I've been treating them, I've been advising them to use these drops 3 times a day. I've suggested they take some Omega because they had some element of MVD. I have performed a Zest treatment or an exfoliating treatment because they had evidence of blepharitis. They'll be impressed, and it also builds that trust there. So what can you offer in-house? We've got the IPL. I won't go too much into IPL. I think that's the whole webinar in itself. And IPL is great. I love it. The whole team at OCL, we do love the IPL. When it works, it's fantastic. It doesn't work for everybody. We'll always tell everyone there's a 15% chance it will do nothing. There's an image at the bottom of my colleague. It's a lot of counselling. So forget all the gadgets and gizmos I've got showing up there. A lot of it is talking, and you can ask, you know, anyone that runs a dry eye clinic, you'll know so much of it is counselling and talking and finding out about their lifestyle, their diet. What bed sheets? Is it cotton? Is it satin? Do they have pets? Do they have allergies? So much goes into that, and the counselling's a lot. The BlephX. Roz, do you want to talk a bit about the Zest and the new lids?
Yeah, sure. I mean, we were just talking. I mean, it's always great, right? From my point of view, I do run a dry clinic, so it's and what we're trying to do, we're really trying to restore homeostasis. Nobody really wants to use the heat bag all the time, so we're helping that happen. We're helping that homeostasis stay in place. IPL, fantastic. I haven't got one yet, but I do want one. So we're hoping to get one very soon. Multifactorial answer to a multifactorial disease. The Zest and the new lids and the BlephX, these are all debriding pieces of kit. BlephX is what I used to have quite a lot, and new lids as well. So we're really talking about blepharitis and that biofilm that builds up around the lashes, right? And the Demodex lays their eggs in that biofilm. You've got a lot of bacteria that builds up in there. You've got all these little microorganisms. When you take all that away, you're naturally reducing the inflammation just because you're taking away all those agents. The Zest is just a little bit more than that. So it is a debriding piece of kit. And what it is it's made of ochre, so that's its base ingredient, and that is a natural anti-inflammatory. So what happens when homeostasis breaks down at the cornea gets a message that it sends a message to the lacrimal gland, and the lacrimal gland will have aqueous pumped out with more cytokines in it, more inflammation. That's effectively what happens. And how does Zest reduce that? The polyphenols, the ochre, the agent, the polysaccharide in that just kind of holds on to that cytokine. It doesn't allow it to kind of cause that inflammation. So exactly what I said, it's just working like it's working like a localized anti-inflammatory. The tannins within that product as well knock out the bacteria, and everything just feels a lot more comfortable, and it debrides in the same way as new lids and BlephX does, but it's a lot more comfortable.
Thanks, Roz. So what can you offer to take away? Look, there is these are the in-house and the at-home treatments, what you take away, and it's what's in those eye drops and what you provide. You've got the warm compress, so you've got hypochlorous spray, which is great actually. You've got a whole host of different eye drops you can use. You've got the new lids, you've got the Peep Club, the wand, which I actually love. I think patients quite like it too. I don't know if any of you tried to use it. It just feels nice on the skin, full stop. It is warming. I quite like heat, and it's really warming around the eyes as well. And that's just good if someone doesn't want to do the warm mask and sit there and not being able to see. Actually, they can just do the Peep Club little wand, which is great. Then you've got different types of solution and wipes that they can use on their eyelashes, and the Zocu Shield, which my patients love. I mean, it's pricey. None of these are particularly cheap, so to speak, but you know, hopefully a lot of these things are short term. Ros, is there anything you want to talk about, anything specific on there?
I think, yeah, I mean, I think we're just talking about this, isn't it? I mean, I'm looking at this in two ways. I can see straight away how we as high street clinicians could be helping support, you know, clinics like yourselves, OCL, very, very well. And actually helping ourselves in many ways as well, because we're managing patients' expectations. They're coming in under, like, they know they've got something that they've got to manage before they go in for an operation, and vice versa. And that's what I saw some questions coming up about the fact that I mentioned baby shampoo. I'm not saying go and use baby shampoo now. What I'm saying is that that's where it started. Surgeons have always known that front surface, the ocular surface, has to be clean. They didn't understand the fact that the tear film was actually causing such a lot of instability. And yes, by using baby shampoo, you're completely destabilizing that. All of these products here, in one way or another, actually enhance the tear film. That is the difference, okay? So whether you're debriding or whether you're putting a supplement in. So when we talk about artificial tears, I've got a bit of I've started not using that in practice, because patients kind of tend to think that that's me replacing their tear film. It's not. It's a supplement. It's supporting the tear film. And if you start thinking about it that way, then you'll start understanding why you're using different agents and different drops, because they will all have different supplementary benefits to that tear film. If we talk about hypochlorous, that is one of the biggest no-brainers out there. It completely enhances and harmonizes the front surface of the eye. It really reduces inflammation, and it's a really gentle treatment to have, and it really manages blepharitis very well. And we can go into that in a bit more detail too. I'm very conscious of the time as well. I know it's sort of like getting to 8:10 already. So Purvi, let's move on a little bit. Yeah.
So these are the different eye drops that you can take, and perhaps we don't need to go into too much. But what I would say is 100% know what's inside your eye drop.
Absolutely.
If I ever give an eye drop to anyone, I'll know what's in it and why I'm giving it to them. If you tell them this is what's in it, this is why I'm giving it to you, they're going to use the one you specified to use. Sometimes they'll present me with an eye drop. I'm using this one. I won't know what it is, and I'll look it up. So let me see what's in it, and let's see what I recognise. So you know, I don't know every eye drop, and I'm sure, hopefully, maybe some of you do, but I'm sure many of us don't know every single one out there.
Absolutely.
Just know what you're using and why you're using it.
Absolutely. I think it's really important, Purvi, isn't it, as well, that, you know, we see new things come out. Actually look at what is in that new eye drop that's come out. I mean, we've just looked at that triple action drop, which I know is a pretty new one from us at the Body Doctor.
Yeah.
It's a lot like the Taylor's Duo, but with an added lipid layer, right? So it's just Taylor's Duo on steroids, if you like. You know, it's really, you know, it's just it's a bit of an enhanced one, and I've got a lot of patients that are liking it. So, but I digress. I'll let you carry on.
So how do you look? I always use preservative free. I know the Body Doctor at one point you do have some preserved eye drops, and I don't. And I'm very honest, I don't use them.
Yeah.
I always prefer preservative free, but there's a place for preservative eye drops. Look, they're more economical, right? Patients, if they can't afford these preservative free ones, sometimes something's better than nothing. So you can always use other ones. We know it's sodium hyaluronate, it's the eye's natural lubricant. And there's bits about sodium hyaluronate we don't necessarily need to get into, just because I am conscious of time. But Pearl 3, know what's in your drop. Your patients will trust you, and they'll be more compliant. Also, I don't know if you ever walked into a shop. I've done this once when I had to buy some mouthwash for some mouth ulcers. I thought, well, you know, I'm an optometrist. I can figure this out. I walked in. I had no idea what mouthwash to use. There were so many different styles. I'm not a dentist. I'm not a hygienist. I had no idea. That's what your patients feel. They go into a shop, you tell them to buy some eye drops. They don't know which ones, you know, and they'll pick up the cheapest maybe. So make sure you educate them and give them from your practice. These are drops you need. Come and see me when you need more. Can you just increase the viscosity? Can we just make them thicker? I mean, they have their place for sure, but for me, their place is at nighttime when their eyes might be a little bit more exposed and they need the extra coverage to prevent the evaporation. But just being thicker doesn't necessarily mean better. So know what's in them. Short chain versus long chain versus cross-linked. Cross-linked sodium hyalonate might just last longer on your eyes, you know, so your patients are using it a bit less. So think about those patients that can only, you know, they don't have the manual dexterity. Cataract patients, they can't put drops in every 2 hours. Have one that lasts a little bit longer on the eye. So think about a cross-linked sodium hyalonate or a long chain for sure. We know this is a video about how the cross-linked version works actually. And you can see the first is a non-cross-linked version, the drop they're putting in, you know, it kind of dissolves very quickly into the solution. And then if you have a little look at the same drop into a cross-linked solution, you'll see that the drop itself attracts the water more. So it kind of keeps its shape and its structure. So it just has that.
Next container, you can see that it's cross-linking, where the elements are turning into small pools. This demonstrates how all the moisture is held together and holds onto the moisture for longer.
So that's just a cross-linked version. But likewise, for lubricating, if it's not a cross-link, you want high molecular weight, you want long chains, just make sure you know what's in them. Medications, like now, my other thing is you don't, Ros, we were talking about this earlier, you don't have to be IP trained to know what drops or drugs they should be using. You could even write to their GP. So limecycline we talked about are often used for patients who have ocular rosacea, might put them on it before they have their cataract surgery. Softacort we've talked about. Soolantra is it's ivermectin, but it's really good for rosacea. And actually people have been using, and I've used it on a couple of times actually, for Demodex. So you ask patients, it's off license 100%.
Yeah.
But you put it on their closed eyelid overnight, make sure it doesn't go into the eye, and it's really good for Demodex patients. Vitamin D, we know there's now a link, Ros, vitamin D and dry eye.
Absolutely, the receptors, inflammation, exactly, it's all linked together. And you're talking about drops, we're actually talking about the fact that we've just listened to how cataract surgery has been done, we've listened to topography. If we can talk to our patients about, for example, I don't have an IP qualification, but I can definitely talk about things and advise patients what they could be probably looking for, what they're going to experience, what could happen, how long they may use this for, etc. And that's really useful for a patient because they will often trust you more than they will the surgeon they're going in to see, because if they're going through the NHS, those guys don't have time to explain all this to them, but you do. You can help manage their expectations. Exactly. And you can help manage the problems that could be occurring.
And then just a couple of extra things that I sometimes use, azithromycin. If you don't want to give limecycline, if it's just for blepharitis patients, there's no signs of rosacea, azithromycin is a much shorter course that you can use rather than limecycline that tends to be 2 months worth, or azithromycin drops. You don't have to give them oral medication, you can just use the azithromycin drops. Or likewise, Icurvis, cyclosporin has its own place for certain types of patients going through ocular surface disease. So a quick summary, hopefully you found that you can identify which patients you're referring for cataract surgery that have dry eyes. The risk factors, know the risk factors of patients sat in front of you, manage and educate them on the implications of untreated dry eye. We do not want to tip them over from asymptomatic to symptomatic. Some patients will naturally be tipped over because of the surgery. If they're aware, they'll be okay with it. If they're unaware, they'll be deeply unhappy. The refractive outcomes, look, if it was me going for cataract surgery, I would put myself on a whole host of things. And actually my parents, both of them had cataract surgery. My mum had elective surgery. She wanted trifocals. I heavily treated her ocular surface before we did the barometry. She's had a great outcome, but definitely, just make sure you treat the ocular surface beforehand. The implications we talked about, the vision, the simple treatments, the best thing, patients are going to be using a lot of eye drops. They might not be so they might not have the dexterity about them. You don't want to give them 100 things to do. Simple things, a lubricating drop, a warm compress or a lid hygiene, and our environmental dietary advice. Simple. And you can do this without taking much of your chair time, but forming that trust, and then giving them products that you recommend. Sell the products to them. They're going to be good. I'm giving you this because of that reason. You're naturally building up your dry eye service right there. more advanced treatments. So there's other things that are available. We don't need to go into them, but just know that they're out there, other things if you want to go more in depth. We talked about the causes. And thank you very much. Roz, thank you so much. This is a QR code, actually. I don't know if you want to take over with the QR code and...
Yeah, thanks a lot, Purvi. That was absolutely amazing. I mean, we do actually look at cataract surgery, and we look at our patients in the practice that I work in quite a lot of ways, but this has been quite informative for me to understand what goes on in your clinic and how you can probably help support that more from a management point of view of just talking to the patients and setting their expectations. And I guess, guys, if we're looking at this as a business, you could even have a pack where Purvi's just said you could have like an eye drop, a heat bag, maybe some hypochlorous. Maybe they have that pack before they go in for their biometry, sent by us. That would be a really good thing. Would you find that helpful, Purvi?
Yeah, definitely. I think those kind of things work really well. So we do have things that we give our patients when we know that they're going to need a better biometry because the first one wasn't good enough. And then we say, go and do all this, here's your pack, come back and we'll repeat everything.
So that would be really useful for us to do. Well, guys, I know I've seen questions flying in at the end. Hopefully Rihanna will be here in any second now. And I know there's been a lot. Hello, she just appears like a genie out of nowhere, just like that. I hope you guys got the QR code at the end. Remember, if you didn't, you can email us and we'll sort you out on that. Are there any major questions that have come through, Rihanna? I mean, I could just see the screen was flashing like crazy on the side. Are there any particular ones that you can direct to Purvi or myself?
So, first of all, I want to say a massive well done, and it was just amazing from both of you. It was actually really, really insightful. When I was listening, I was like, Jesus Christ, what is going on?
Yeah, I know. It's amazing what we can do, right?
Honestly, I was watching the videos and I was like, Jesus.
Yeah, it's very good. I think the most important thing for me to take from this is the fact that how much we as high street opticians can actually help support clinics like yours, Purvi, and make such a difference to that patient's journey, just with little things like eye drops, heat bag, wipes. If you can't, if people can't get drops in, use that hypochlorous spray. It's so easy. That compliance is nothing. So yeah, are there anything major that's come out that you really want to talk about or that's come through, or anything consistent there, Rihanna?
So I'll start from near about the top and I'll get to as many as I can as possible. One of the first ones that's poking out to me is from Andrew, and he said, are you routinely checking tear film before surgery?
On everybody. Yeah, every single person that comes in for surgery will have a slit lamp examination for sure, with a proper ocular surface review. We know the impact it has, and hopefully this talk has highlighted the impact that it can have. And look, we're obviously a private clinic. We want our results to be absolutely spot on. That's what we go on, our excellence and what we do and delivering what patients have come in for. And this is a huge element of it.
I think, yeah, absolutely. I think if I'm thinking about it from not from your clinic point of view, but from a clinician that's actually on the high street, we do send patients to you. It's great, but some of our patients can't afford that, right? But it doesn't mean that they can't have some sort of access to better biometry. And I think hopefully everybody on this call can understand that just by doing a little bit of work, taking just a few minutes of attention, whether that's your OAs that you train, whether if you've got a contact lens optician like me that actually looks after this kind of stuff, that's another thing. But we can actually have an impact on this, and it's not anything new. It really isn't.
Another one, I think these guys were just having a little bit of a chat between themselves, but I'm sure one of you will be able to clear it up. So someone said, I thought with baby shampoo being a detergent, it helped the blepharitis but caused dry eye.
It does. It absolutely does.
Is that exactly right?
Yeah, so it completely destabilizes the tear film, and we don't use it anymore for that reason. But the reason it was used initially back in the 60s is because surgeons knew that they needed that front surface to be very clean so that they wouldn't have any problems. Am I right, surgery? I'm sorry. Am I right, Purvi, on that?
Yeah. You're definitely right. I agree with you there.
Exactly. So that's why, but we've realised subsequently that what happened was where it was only supposed to be used around surgery, patients continued to use it, and it just made their eyes drier and drier and drier. So it was only supposed to be used for a very short period of time to make sure there weren't any complications post-surgery. And they had the best possible effects. And they didn't have the kind of stuff that we have now. You know, even their eye drops weren't as sophisticated as we have at the moment. So we don't need to go in that direction. We just need to understand that it was recognised even back then that the ocular surface had to be a lot in a much better condition than it is generally.
The risk of infection as well was huge at that time as well.
Yeah.
Right? You need to make sure that the eyelid margins were clear of any debris, bacteria, because the risk then, you know, incisions are much smaller now. Back then, incisions were a bit bigger. There's more risk of bacterial going into the eye, risk of endophthalmitis. So likewise, it still happens now. You know, we still have to make sure that there's no bacteria going into the eye with the risk of developing any severe infection.
And then another one I've got is there any evidence that Zest treatment can be done as an adjunct to IPL, and is that effective in managing bleph and dry eye?
Go ahead.
Evidence-based, actually, I think there was a little study done recently in using Zest together with IPL. It might have been done with the Luminous team, actually.
Yeah.
In using Zest in conjunction with IPL, and 100% we often use it together as well.
So what I'm hearing, I mean, I don't have IPL in my practice, but what I am hearing when I'm talking to different clinicians is that because it reduces the inflammation, especially on that first treatment, it really, it just gives a much better result, and it allows the glands to express a lot easier, and you don't get as much discomfort. So that's what I've heard back from quite a few of them.
And likewise, the IPL has a greater effect so IPL works on the meibomian glands, right? When they're very solid and very full, the light doesn't penetrate as well. As the glands start to empty and the meibomian glands become less solid, you're getting more penetration of that light. So the effectiveness of the IPL is greatly increased. You add a Zest into that, you're naturally reducing inflammation. You're adding that cumulative effect of getting the glands a little bit lighter, not so dense. So the IPL has a greater effect, therefore. So it all works really well in conjunction together.
So that's a really good explanation, right, of why that makes sense of why it should really work. And as far as Demodex goes, isn't it just about, I mean, I'm sure if we all got hit with that much sort of energy, we'd all probably explode, wouldn't we? So, you know what I mean? So that kind of makes, I don't need to go into too much science behind that one. But as far as Zest and Demodex goes, or any treatment really with Demodex, because I did see one of the questions coming up, why does Demodex come back? We do need Demodex. Like everybody on this call has Demodex, right? It's actually a really good microorganism. It cleans the face. It does it does a really good job. It's just if their numbers get too high. So what we're trying to do is we're trying to break that breeding cycle so their numbers are kept under control. So they absolutely will come back, and we need them to come up. We just don't need them to tip over. A bit like, symptomatic and asymptomatic we've just been talking about. Exactly that.
Another question is, can you use both Zest and BlephX in one sitting with a patient?
You wouldn't need to, because Zest debrides.
I have used both in one session.
Have you? Do you disagree?
No, I don't disagree whatsoever. There's been one time where I did a Zest, and there was just this one that wouldn't go, and I always put them back on the slit lamp after to have a look.
Yeah,
and I did the BlephX because I could just absolutely, and to be fair, with the BlephX, I then took the eyelash off. So I definitely cleared the bleph because it cleared the eyelash.
And the eyelashes at the same time. So again, I guess what we're saying is, I mean, to be honest, routinely that sounds like a no. And if I'm thinking about what I do in practice as well, there's been one time, which I'm a bit like you, there was just that little bit that I couldn't remove, and I just got my new lids out and zapped it and got rid of it. Because it was just so heavy and so impact. And probably if I'd left the Zest on there longer and just pushed a bit more, I probably would have got it off. But really, Zest is a debriding piece of equipment as well as an anti-inflammatory.
Mm-hmm. Another one is, how soon before cataract surgery must the dry eye / bleph be treated? I.e., can the patient carry on treatment, warm compresses, eyelid wipes, etc. until the day of surgery, and can they carry on with it immediately post-op?
So pre-operatively, yes, there's nothing in there that's going to change anything. What we don't want is then to do some damage to the cornea. So I tend to say the day before, just stop everything, just in case they accidentally using their wipe and they swipe away some of the epithelium from the cornea. We don't want a pristine cornea going into surgery. So the day before, I tend to stop. Post-op, I did discuss this actually a little bit, but I don't know if you agree, I just don't like heat and inflammation, you know, so I tend to say don't. And also, sometimes a warm compress, you don't know how much, sometimes patients just press it onto their face when they don't need to. You don't necessarily want that weight onto a wound as well.
Yeah,
It's a clean wound, so I tend to say nothing for 4 weeks. Apart from the lubricating drops and some eyelid wipes, they can start usually after a week. I say you can start doing some eyelid wipes. And the warm compress, I tend to say 4 weeks.
I'm a bit like you, Purvi. Yeah, I'm a bit like you. I don't really want heat around that area. I don't really, you know, that's not something that I'm big on. I actually tend to go towards the hypochlorous as opposed to, so I was going to actually ask you about that. Have you ever thought about doing that? Because I've started easing away from them touching that area at all, but just using hypochlorous to keep it a bit clear. Don't know, what do you think?
That's a really good idea. Actually, we don't routinely give hypochlorous to all the patients to use beforehand, but it makes sense to.
Yeah, and just afterwards,
of how much do we do and how much do we just refrain from doing? It's treating it without overkilling it. We don't need to get apprehensive about the fact they're having to do all this because they've, gosh, God forbid, they're having cataract surgery. Actually, cataract surgery is relaxing surgery, you know. So
yeah, no, I meant afterwards. You know, afterwards, I don't really want heat afterwards. Yeah, so I tend to. I've moved away from the wipes and actually gone to hypochlorous for that.
Yeah, I didn't think of that actually. That's
yeah, it's just a bit easier. You're not touching that area at all, no heat, no whatever on it, and it just keeps it all nice and clear. So that's what I've started doing anyway.
That's a good plan, actually. Very good.
I'll start wrapping it up, but here is another one. Do you guys know of any SA drops that are cross-linked off the top of your head?
I use one. It's the Aeon one. It's the yellow. It's the only one for pre and post surgery. So it's an Aeon eye drop. And it's cross-linked. I think VisuXL also do a cross-linked one. I used to use that a little while ago, actually, but I haven't used it in a long, long time. I now use the A one. It's specifically made for surgery, so that's the one I tend to go with.
Yeah, VisuXL, that's what Laura's just saying there as well. So, okay.
Yeah, thanks, Laura. I'm glad I wasn't wrong. I did remember using the VisuXL.
Another one is, how do high volume, low complexity clinics manage this exceptionally important part of assessment / expectation for the patients?
I mean, look, I think you have to, I do understand, which is why I said in an NHS clinic, you cannot do this. There is no time to do this. It wouldn't work, right? And I'm not saying the NHS department should be doing this, or even places with NHS contracts, but when we send that referral, we could start the process because they don't have the time to do it. So we should start it. And I'm pretty sure they put everyone on a slit lamp just to have a little look. And maybe if they're looking and the ocular surface is so poor, and also don't forget, in the NHS, where you have contracts, they're not using trifocals. They may not be using toric lenses as much. They just want to get the cataract out and hope for a good visual outcome. But they're not saying to patients, you're going to be spectacle free. There may be 1 diopter still, 1.5 diopter still. If they come out a little bit myopic or hypermetropic, well, you can see with glasses, go and get some glasses. So their expectations are a little bit different to, I suppose, where I work. I mean, I also work in the NHS in Luton, and I know that they don't have the time to do all of this, you know, in depth, but patients don't have that expectation. They know they may well have to wear glasses, definitely for reading, unless they're having monovisions, and they're quite happy. But
I think it's interesting as well. I took that question a different way, actually. I was thinking about it more from, what about if you work in a multiple setting and you're going through patients quite a lot? So how can you, if like you're referring, definitely, because you can see they have a cataract, but like how can you help support the NHS? And if you haven't got time to do a dry assessment, I think I would go back to your initial slide, Purvi, which shows that most patients that are coming through that door, because they're older and they're in that kind of susceptible category of probably having dry eye, they're in that element of the population that is going to be there, whether they're menopausal, whether they're, you know, whether it's gender, and these hormones are starting to change as well, all sorts of aspects. So we could probably say that, is there a case to be said that actually, if you're going for cataract surgery, whether it's the NHS, whether it's a private clinic, we know that probably 9 times out of 10 they need to have that front surface stabilized, whether they've got official dry eye or not. There's no two ways about it, right? So therefore, maybe we should be just saying, right, here's a hypochlorous spray, here's some drops, here's a heat bag, start using this before you even get to the NHS for your appointment. Is that a way to kind of manage this? Because effectively your opening slide suggests exactly that. And if we look at the rate of dry eye, it's something like about 80% of the population now, isn't it? It's the new pandemic or something like that.
Actually, Justin's here. Justine has just made a good point. The NHS surgery is to get rid of the blur and the cataract, not for refractive purposes. Exactly that. They're there to do the cataract surgery, and they will try and get the best refractive they can. They don't have the time for the ocular surface, so you might come out a bit myopic, a bit hypermetropic, you might have SIL, but we could help them along the way and say, look, let's have the best scans. I'm referring you, start using these drops, and hopefully, you know, we can get rid of the cataract for sure and get us close to where we want visually as well. So that's all.
Yeah, absolutely. So we've got a way of influencing that outcome.
Exactly.
Absolutely, and making quality of life a lot better. I think that last, you know, the last guy, the one that was a paraplegic that you saw, the quadriplegic guy, that actually struck a chord with me, because that was real quality of life. And actually, we all have that to a greater, lesser degree, not to that degree, but we all have quality of life issues, right? So the better we can get a quality of life, and that's really the industry that we're in, it's about quality of life, then we've got to try and support that with one way or another.
For sure.
I've came to the bottom of the questions now. The last one I can catch is, if someone does have bleph and we start treatment, how long do they need to treat before giving them a date for the surgery?
Look, it depends. I think by the time you send that referral in, you could definitely treat their bleph, and their tear film will be better. It depends. You're going to weigh up them needing cataract surgery depending on how bad the cataracts are versus their ocular surface, and they'd probably be better off getting their cataracts out. But it's not going to happen instantaneously. It'll probably be at least a month before they have it done. So a month is plenty of time to get things more prepped.
Perfect. There is one more that I've just caught, and it says, can you perform cataract surgery with GA?
Yeah, you can do. So I mean, now it's done with, you know, it's done with a local anaesthetic, mild sedation if you want it. In NHS, it will just be local anaesthetic. But for those patients that need a GA, it's very rarely done, but I believe they do it. Very
perfect.
rarely.
Okay, so guys, has everybody got their QR code or all of those kind of things?
If you did want it back up, shall I just pop it?
Yeah, could you pop it back up?
Pop it back on the screen, yeah, because there was a few that didn't quite catch it.
Yeah.
If no one has caught it, there will be an email sent straight after this finishes from WebEx that will have all the details on it. And like I said at the start, if you're struggling with anything, just email us.
Rhiannon, will you put the email address in the chat as well, please? Is that all right?
Yeah, if you just send it to marketing, Emma will get it sorted for you.
Purvi, thank you so much. It has been an absolute pleasure working with you today. It really has. And thank you for the presentation. That was all Purvi, guys. She put that presentation together. I just fiddled around on the edges and she was amazing. So thank you. It's been a pleasure working with you.
It's been a pleasure to be on and to have this webinar with you. It's been great. Thank you so much, Roz. And thanks, Rhiannon, for you for being a great moderator and for the body doctor for having me.
Really, really good job, Rhiannon. I mean, it's the first. I mean, I'm sure you don't mind me saying this is the first time that Rhiannon's done it. She's
all right,
smart, guys.
Thank you.
Absolutely. All right. Thank you very much, guys. Have a lovely evening. Thanks for attending.